All right.
Good morning.
Yeah. Yeah, Dita. Sorry, I can. Did you want to go ahead, or you want me to?
Yes, I can go ahead.
Yes,
Okay, good
please. Yes,
morning.
please.
Right. Good morning, everyone. And I am Dita. I'm part of the AREP. Currently, I'm in Texas. So today's session, we will have speaker Dr. Jenny Huang from Johns Hopkins School of Medicine and Dr. Balakrishnan as a moderator from Qatar. So AREP is we've been doing this for the past 3 years, and it's an like educational project uh based in the US and reaching out to Asia and Mongolia, Middle East, and also some of the African countries. So and every month we hold it like a different topics, and we will and this session is the last session of this year, and then we will start the next session in 2025 January. And today I would introduce you our moderator, Dr. Sidin Balakrishnan. He is now residing in Qatar in Hamad Medical Center, and he is very into the I think it's in a technical for medical field. And Dr. Balakrishnan, the floor is yours. You may introduce Dr. Huang.
Thank you, Dr. Andita.
Yes, JP.
Can you
Yes,
hear me?
sorry.
Can everyone hear well?
Sorry. Yeah, just wanted to. Yeah, this is JP. Sorry, Shidan. Thank you so much. Yeah, just wanted to say Shidan is a great friend of mine, and then he's also a clinical research scientist and principal investigator at Department of Surgery in Hamad Medical Corporation, which is one of the largest healthcare providers in the Middle East. And he has over a decade of experience in surgical innovation. And his main research focuses on optimizing patient outcomes in robotic-assisted surgeries through the AI and augmented reality. So he's working in all these futuristic radiology things. So he's also secured a million grant and a $1 million grant in research funding as a lead principal investigator from prestigious national organization, which is Qatar National Research Fund. And he's been cited more than 600 times and have resulted in more than 50 plus R&D outputs so far. So yeah, just wanted to just give a personal touch on that. Welcome to you, Dr. Shiran. Please go
Thank
ahead.
you. Thank you. Thank you so much, JP. And good morning, afternoon, evening to everyone. I know we are all over time zones, so welcome everyone. And thank you so much for joining us today on a Sunday, which when most of you are off, radiology education program for organizing a webinar of such high caliber. And I'm sure your efforts will truly create a difference in the way radiologists are being trained. Now it is my pleasure to introduce our distinguished speaker, a dedicated national leader in clinical research and education, Dr. Jenny Huang. Dr. Huang is a full professor of radiology at Johns Hopkins, where she also serves as the vice chair of radiology enterprise integration and medical director of Johns Hopkins Imaging. She completed fellowships in both neuroradiology and cardiothoracic radiology at Duke University Medical Center and earned a Master of Health Science from Duke University. Further demonstrating her commitment to lifelong learning, Dr. Huang recently graduated in the top 10 BA, earning the title of Fuqua Scholar. So from my side, I tried to find out how you would pronounce Fuqua. And the first link told me that because a few qualified, it's Fuqua. So it's it's amazing, and it's such an honor to be in the presence of such a guest. Dr. Huang has made substantial contributions to the field of thyroid and parathyroid imaging, publishing more than 100 peer-reviewed articles on the topic itself. Notably, she led the American College of Radiologists efforts in producing a white paper on incidental thyroid findings and served as a core member of the ACR TIRADS committee, where her work has been instrumental in standardizing the management of thyroid nodules. She also actively contributes to several committees of the American College of Radiology, including the Incidental Findings Committee. With her extensive experience and national leadership in advancing imaging standards, Dr. Huang is uniquely positioned to share with us her expertise through her talk today. And we are very fortunate to have her with us today, and I'm confident that we will all learn immensely from her insights. Before I hand off the stage to her, a few housekeeping rules. Everyone is kindly requested to please mute your microphones during the lecture, unless absolutely necessary. We will have dedicated time after the lecture for a Q&A session, but feel free to use the chat box to send in your questions during the talk. I will compile them at the end of the lecture and send them to Dr. Huang to respond. With that being said, please join me in welcoming Dr. Huang. Dr. Huang, the stage is yours.
Thank you so much, Shidan, Dita, and JP. It's a pleasure to be here. It's currently Sunday morning at a few minutes past 9 on the East Coast in Baltimore, where I am. I've got a lot of fun things planned for today, and this is one of them. So it's really a pleasure to be with you, and thank you for everyone for joining live. I have honestly been passionate about the thyroid nodule problem we have all throughout the world, maybe more so in the United States, but it's all throughout the world. So it's honestly one of the ways all of you can make a huge impact on patients. And hopefully in this 45 minutes, an hour that we have, I'll convince you that what you do really matters. You should care. You should most certainly bother with guidelines, and then update with you on what's new coming from the United States and ACR. Hopefully that sounds good to you. So I'll move on. I don't have any disclosures. My only disclosure is that I am incredibly biased towards ACR TIRADS. I don't know what guidelines you use predominantly in your country or institution, but there are, at last count, more than 9 guidelines throughout the world, and ACR TIRADS is just one of them. My career started off with incidental thyroid nodules, and that was published a set of guidelines in 2015 and ACR TIRADS in 2017. So now that we're, close to a decade after ACR TIRADS, there are certainly papers that have come out that have shed some insight on how the guidelines compare with each other. So I'll share some of that with you. Here are the objectives and the guideline, the outline for this talk. I will give an overview of ACR TIRADS. I will try and convince you, successfully, I'm sure, why you should care about thyroid nodules and why I did many years ago and embarked on this career of focusing on thyroid nodules. Then why you should bother with guidelines, do they even matter? Which ones you use, and then some challenges that we still have almost 10 years out, and some updates from ACR. So let me take you back to when I was much younger and had fewer gray hairs, back in 2015. At this stage, we didn't have ACR TIRADS. And in the United States, members of the American College of Radiology were coming to us frustrated. And I knew this because I started lecturing on incidental thyroid nodules with the white paper on incidental thyroid nodules. And I thought I had made, significant progress with the ACR. And people after the lecture came up to me and said, we've still got this problem with biopsying. I'm biopsying too many thyroid nodules. I hate dictating thyroid ultrasounds and dictating, more than 10 thyroid nodules in a patient. And I realized this is really where the problem lies. Maybe it's not just the incidental thyroid nodules, but it's also stemming from the ultrasounds. And so at that stage, no wonder we had this problem. We were either using no guidelines at all for thyroid nodules and letting the radiologist just describe thyroid nodules, or we were using a very outdated SRU system. That's the Society of Radiology and Ultrasound. That was published back in 2005. And thyroid ultrasound was increasing in the United States. It was more than 20% increase in volume of diagnostic thyroid ultrasound per year over 5 years. So we were really encountering an epidemic in the growth of thyroid ultrasound. But more than that, what we realized from study from Davies and Welsh, which was published in JAMA, is that we were encountering an epidemic in thyroid cancer. And when I presented to you 2 years ago, I may have touched on this. You may have seen graphs like this, but this is the one really important slide, I think, and it's in all my lectures. So in a matter of 4 decades, thyroid cancer diagnoses was increasing, and it was increasing by threefold in 4 decades. And in that time, it was not all thyroid cancers that were increasing because, as you know, there are 4 main types. There's papillary, follicular, medullary, and anaplastic. They're the 4 main types. And it wasn't all of them that were increasing at the same rate. 87% of the excess cancers over this time were papillary thyroid cancers less than 2 centimeters. Papillary thyroid cancer is the more indolent thyroid cancer, and we're detecting small cancers. And so, one of the arguments is if we're detecting and treating these cancers when they're small, surely we're saving lives. And it's really lives saved that matters, not the survival time. And so are we saving more lives by diagnosing and treating small cancers early on? And we weren't. Mortality was low in general, and mortality had remained essentially completely flat over these last 4 decades while we spent more time diagnosing, treating more cancers. And so the authors of this paper said this is not due to a growth in thyroid cancer incidence due to biology changes like diet. It's not due to environmental factors. This is entirely due to overdiagnosis. We're merely just detecting more thyroid cancers, and we're not making any impact on mortality. And so where are we detecting these thyroid cancers? It's imaging. It's us, the radiologists. If you can imagine back in 1975 and the 1980s, before thyroid ultrasound, the way we were detecting thyroid cancers is when patients presented with a palpable mass. But with imaging, we're suddenly detecting these thyroid cancers when they're no longer palpable. So back in the 80s, we started with ultrasound. 80s and 90s, we did ultrasound-guided biopsy. And remember, thyroid is one of those superficial organs that's so easy to access. It's different from an adrenal nodule or a renal lesion. And then with the time that I was from a resident to now attending, I've seen a massive increase in use of CT where we're detecting incidental thyroid nodules. And with all of that, after 2 decades of imaging, it wasn't until 2005 that we had the first criteria in the United States. This is the SIU criteria, which told us which thyroid nodules that we might choose to biopsy and which not to. So at this stage, looking down at the top of this curve, I personally had this sickening feeling that what have we done as a radiology community, and where do we go forward? And so the American College of Radiology also felt the same, and that's why we embarked on the ACR TIRADS project. And this project took a long time. It was close to 2 years. But here is what ACR TIRADS essentially looks like. And for all of you that practice daily, I'm sure you know it, but let me just provide an overview. There are 5 category of findings that every thyroid nodule should be evaluated upon. And for all of them except for echogenicity, you just choose one. There are higher points based on more suspicious findings. So very hyperechoic is more than anechoic. And based on these 5 features, you add up the points and it gives you a TR level. And then based on assigning the TR level, you then look at the size of the nodule and then determine whether it is for FNA or whether it's for follow-up. So ACR TIRADS is based on 5 features, summing the points, and then applying a size criteria. There is another version of this table or graph or pictorial, and this is it. It's on the ACR TIRADS website, and this is just another way of looking at it. For every nodule, you're always going to have the composition and echogenicity. And then after that, there are suspicious features that are less common that you can add. So this is another way of looking at it. So you can see if something is solid and very echogenous, is very hypoechoic, then it's already got 5 points. So it's definitely going to be at least a 4, if not a 5. Okay. All right, so let's focus on what would warrant action, and it's TR3 to 5. For TR1 to 2, you don't even need to report those nodules. And so TR3 to 5, there's this reliance on size. And so why does size matter? Size, and this is important to know, that there's no other RADS product that is applying size after you apply the level of suspicion. And this is somewhat nerve-wracking to some people, that you would have a potentially highly suspicious thyroid nodule for cancer, yet you're potentially going to leave it if it's less than 5 millimeters. Well, yes, you actually do not report it if it's less than 5 millimeters, because size is not it doesn't predict malignancy unless you've got a size, say, more than 4 centimeters. But thyroid cancers are incredibly indolent, and so size helps us, in a way, titrate how many nodules we're going to biopsy. You can see the rate of malignancy here after looking at meta-analyses. This one is one of the largest by Kai. For a TR5 nodule, you've got something like a 35 to 80% chance of it being malignant, TR4, 10 to 60%, TR3, 2 to 5%. So the way I look at it, a TR5 is about 50%, a TR4 is about 30, 40%, and TR3, it's really going to be less than that 5%. And so when we actually look at the ACR TIRADS registry, by applying these size thresholds, that's exactly what's happening. We are actually biopsying about 60% of TR5 nodules, 40% of TR4 nodules, and unfortunately still about 30% of TR3 nodules with these size criteria. So one way to look at a new version of ACR TIRADS is that we probably need to increase these size thresholds for TR3. It's the size, I'm going to emphasize again, gives us the yield of the biopsy in diagnosing malignancy. And can we leave thyroid nodules when they're small? Can we leave malignancies when they're small? And the answer to that is yes. And I'm going to emphasize this in the next point. This is from the SEER database in the United States, where all patients with cancers are entered into a registry. And we look at the survival and outcome based on the stage of the thyroid cancer. So for thyroid cancers less than 3 centimeters, you can see the 10-year relative survival is almost 100%. This is taking all histologies, all stages of thyroid cancer. It averages out that if you've got a cancer less than 3 centimeters, your survival is almost 100%. So it is okay to leave these high suspicious malignant cancers when they're less than 5 millimeters. And size here is to determine the yield of the biopsy. So my number one tip is be comfortable leaving thyroid nodules, be comfortable leaving potential high-risk thyroid nodules. You certainly don't want to spend your time dictating all these nodules like this radiologist may have done in Australia. This was sent to me by a friend, Jen Gillespie, who practices in Brisbane. And I can't believe that this patient had a right hemithyroidectomy, but the sonographer on this ultrasound described all these nodules. Can you believe that? I can't. They must have more time in Australia than they do in the United States. My tips are you can be leaving thyroid nodules undetected in your report. Only report thyroid nodules if they're TR 3 to 5 and they warrant an FNA or follow-up. And don't report more than 4 nodules. So even if 5 nodules require follow-up, you only need to report the 4 most suspicious or the 4 that need an FNA. And we recommend not biopsying more than 2 nodules. So even if 3 nodules need an FNA, you recommend a FNA on the 2 the 2 with the highest points. And one key thing that we've learned, and in the new version of ACR TIRADS, we certainly won't do anymore, is that it's not helpful to put in these descriptors, mild, moderately, highly suspicious, because patients are going to get worried if you say that there's a moderately suspicious nodule, yet you're only recommending follow-up. So it's just easier to say it's TR 3, 4, and 5. Okay, so we can take a stretch. Why should you care about thyroid nodules? Now, I would say that of all the things you do, the thyroid nodule that you see on imaging, what you do with that in your report, that's the way you're going to make the most impact for the day. One of the ways. Your report makes a big difference. Your report sets off a domino effect. You don't want to be wasteful. And I'm going to tell you my 3-2-1 rule that I tell the trainees in the room all the time. And finally, you want the best for your patient. So they're the 3 reasons you should care about thyroid nodules. This is an email that I got from one of the thyroid surgeons at Hopkins, and I've blocked out some names and just blocked out some of the irrelevant bits. So she's calling for help. My friend Lila, the thyroid surgeon, is saying, we are inundated by reads from this practice with examples below. The patients are so anxious to be sent for surgical consultation. I appreciate any thoughts you have on this. So, what was Lila's example? What was she telling me? This is the example. She sent a report that said from this outside practice that there's a nodule that's measuring up to 1 centimeter. It's got mixed solid and cystic components. Where the nodule is, and it's with a TIRADS score of 4, mildly suspicious. So we know that a TIRADS score of 4 is not mildly suspicious. That's moderately suspicious. But what could this radiologist be seeing? They've only reported the composition, only the composition. So they've said they've talked about TIRADS, but they haven't applied or mentioned any of the 4 other findings. So a mixed cystic solid would only give you 1 point. So to get to 4 points, they must be thinking this nodule is at least hypoechoic to get 4 points. But they haven't mentioned that. But it could also be 1 point, which would only be a score of 3, which would make it, which wouldn't mean that it's a TR have 4 points, and it may be mildly suspicious. So just to remind you, if you always need to refer to this, that 3 points would give you mildly suspicious, which they're saying it is. If it was just solely mixed cystic solid, it would only be 2 points. Okay, so at 1 centimeter, if it truly was moderately suspicious and 4 points, it would just be a follow-up. And then if it wasn't, if it was mildly suspicious, which they're saying in the descriptor, it wouldn't even be worth mentioning in the report. So what is this radiologist saying that we should do since they applied ACR TIRADS? They are saying, and this is Lila's problem, they are not advising on whether it needs a biopsy. They are just saying that surgical consult or follow-up is advised as deemed medically necessary, clinically necessary. And so what makes it clinically necessary? And maybe it's risk factors in this patient, but if you're recommending surgical consult on all the nodules you describe, then that is not good practice. And so that's why this surgeon is being inundated with requests for consultation. And so I'm going to say that your report really matters. It sets off this domino effect, and the surgeon on the other end is left kind of holding up the stack of dominoes falling on them because they've just got so many consults for these low yield patients. And at Hopkins, a lot of the biopsies get referred to Hopkins for biopsying. And when our radiologists look at the nodule, they're also thinking, this really doesn't need a biopsy. Why is it coming to me? But at that stage, it's often too late to change the course because the patient's already got fixed in their mind that they need a biopsy. A biopsy is easy to do. It's only superficial. The primary care provider is thinking the same. And so it's often too late to stop the dominoes from falling down. And so whatever we can do to even stop the dominoes from tipping, that is doing the best for the patient. Okay, so then you think, well, it's just a biopsy. It's pretty low, safe procedure. How does it matter anyway? And so this is one of my favorite studies that's honestly come out in the last 5 years. And I wish it were my own, but it's not. This is a study on incidental thyroid nodules seen on chest CT. And the beauty of this study is they follow up these patients for a long time. The study is published in 2022, conducted in early 2020s, and they looked at nodules from 1995 up until 2016. So these nodules all had at least a 10-year follow-up. They determined that about half of the nodules were reported in the impression of the report, and then the other half in the findings. And then they followed these nodules for whether they had thyroid, whether they had an FNA, whether they had surgery, and then to the point of whether they were diagnosed with thyroid cancer, and then when the patient died. So what does it show us about our impact? If we reported what the nodule in the impression, how does that change anything? Because as radiologists, we kind of don't think of what happens after we report in the impression. Okay, so if we reported the nodule in the impression, at 6 months, it is 7 times more likely to be worked up. So 5% compared to 36%. At 12 months, it's now 3 times more likely. And so that just shows us that perhaps some of these nodules that actually end up getting worked up, they got bigger, or the patient presented with actual lymph nodes. So they were declaring themselves. But still, it's 3 times more likely to get worked up. Okay. And then here are the outcomes. We looked at thyroid surgery, diagnosis of thyroid cancer, death from thyroid cancer, and death overall. If the nodule was reported in the impression, it was 3 times more likely to have thyroid surgery. So after that FNA, there must have been something that led to thyroid surgery, and that is statistically significant. But in terms of thyroid cancer, death from thyroid cancer, death overall, you can see none of this is statistically significant between the nodules that were reported in the impression reported in the body. And so this just shows that we are driving up workup, driving up surgery and the cost of that, but not making a difference on what matters, which is overall death, and even death from thyroid cancer. Okay, number 2 reason of why you should care about how you dictate that thyroid nodule, and how you should be very picky on what you let go to biopsy, is waste. And I've given versions of this talk multiple times. And finally, I thought, I present studies. How are people going to remember it? So I've come down to 3-2-1 rule. And this is what I tell my trainees in the reading room. At the beginning of the summer, we have new trainees coming, new fellows from outside, and they don't know me. And they slip in a thyroid nodule in the impression of the report. And I go, hey, hang on. The reason I got promoted is because I've spent a lot of time thinking about this. So I want you to remember this 3-2-1 rule. And so here's my rule. Okay, so 3 is the fact, and I've already shared that with you, that if a thyroid cancer is less than 3 centimeters, the survival is nearly 100% over 10 years. So that to say that thyroid cancers are very indolent overall, and they can be left. The risk, you may be afraid that that thyroid nodule ends up being malignant, but even if it's malignant, the chance of having an impact on survival, if it's less than 3 centimeters, is still pretty low. The second point, 2 is that less than 2% of thyroid nodules on imaging are malignant. And this comes from this study by Rebecca Smith-Beinman from UCSF, who looked at patients that had thyroid ultrasound and whether they had nodules more than 5 millimeters. And she matched these patients, these 8,000 patients, to a Californian thyroid cancer registry, and found that only 1%, 1.6% ended up being malignant. And so that is showing that if you're taking a cohort of nodules without assigning them into risk, the overall risk is less than 2%. In studies that look at outcomes from thyroid nodule biopsy, the fact that those nodules were biopsied suggests that they had more suspicious features. So in those studies where you've got a select bias cohort, you might get 10% to 15% risk malignancy rate. But in incidental nodules where you're taking all comers, it's less than 2%. Okay, and then the 3-2-1 rule. 1, I'm going to cheat a little bit, and that 1 actually represents 1,000. And this applies to the United States. So the 1,000 is that for every procedure after you report that nodule in the impression of the report, you're costing $1,000 or more to either the insurers, our Medicare system in the United States or to the patient, because in my hospital at Bayview, Johns Hopkins Bayview, a thyroid neck ultrasound is more than $1,000. A biopsy, certainly more than $1,000. A lobectomy is more than $8,000. And then molecular testing in the United States is $3,000. So most radiologists and even people that refer patients to these procedures really don't understand the cost. It's not transparent. But once you look at the cost and think, wow, it's more than $1,000. So the 3-2-1 rule, really great survival. If it's less than 3 centimeters, the chance of malignancy less than 2%. And then finally, this workup is incredibly costly, more than $1,000 per procedure. So it really means that you should care about which nodules end up in the impression report and go to biopsy. And finally, as physicians, we all care about our patients. And what's come out more so in the last 5 years since I've been doing this is looking at the financial impact on patients. This study by Barrows tells us that there's a real psychological financial burden on these patients, and more so on thyroid cancer versus non-thyroid cancer. And so for thyroid cancer, patients were surveyed about their psychological financial burden on a standardized survey. And for thyroid cancer, it's 46% compared to other cancers like colon, breast, lung, it's 24%. And that's statistically significant. And then another study which looked at thyroid cancer patients in terms of bankruptcy. So this is actual financial bankruptcy, not just perceived psychological, comparing that with patients without cancer. And these patients have a 3.5 times more likely to file for bankruptcy than other cancers. So let's take a step back. Why is this the case? Why is the impact of thyroid cancer financially more than other cancers? All right, lock it into your head. Okay. And the answer that all of these authors state is that the diagnosis of thyroid cancer is earlier than other cancers. It's often in the 30s in the 40s to early 50s. And at this stage in the United States, we don't have Medicare supporting the patient. So Medicare is, in a way, public insurance for patients over the age of 60, 65 in the United States. So these patients are bearing the burden financially of their cancer treatment on their own. In the United States, they might be insured privately, but there is still out-of-pocket payments that they have to make because insurance doesn't cover 100% of the costs. And then these patients survive a long time. So every year they've got these out-of-pocket costs. And even if you've got a low-grade cancer, or low-risk cancer, you're still getting this follow-up. And then if your cancer is higher risk, higher stage, then there's more cost to that. This is at a time where these patients may be supporting their family, they're still working, and perhaps making this diagnosis of thyroid cancer puts them out of work because they're needing to attend their medical appointments. So making this diagnosis certainly makes an impact on the patient. And if you're talking about bankruptcy, then it's generations of this family after this patient. Really, really sad. Okay, so we are at this point, why do we bother with guidelines? After spending, I told you, 2 years on ACR TIRADS when we first published this paper, this is what they said on the forums. They said these RAD schemas are metastasizing. It's typical to keep track of them all. Another person said, yet another useless classification system that academics have put together to supposedly program us. And then finally, I think you can pick a system and consistently apply it, and you're way ahead of the game. Does it really matter whose system you pick? And in Asia, you might think, whoa, these people in the United States are harsh. Well, some of these comments were anonymous, but some of them weren't. I mean, they were kind of cruel, particularly from the point of view of all of us on the committee spending all this time putting together and attending meetings and this was all, voluntary time. But it also, I guess it's like politics in the United States at the moment. I have this strongly held belief of my views, whether it be thyroid nodules or politically, but it's often helpful to think about the other side. So why would this be the case? And how do we get them to convince them? Okay, so one of the ways to support all of this was to publish papers. And the other way is just for the doubters in the audience today, maybe to help you understand what guidelines do and why you should bother. The goals of guidelines are to reduce the workup of thyroid nodules and reduce overdiagnosis. And that's everything that I've told you up to leading up to this talk, the epidemiology, the impact of the patient, the costs. We want to reduce overdiagnosis. But the other role of these guidelines are to improve the quality of the reports and the recommendations. And this is how we do it. One of the ways is to have standardized reports that are complete. And so that's the role of the 5 findings, using the same lexicon and using structured templates. The other goal of guidelines is that we provide uniform recommendations so that every radiologist, based on what they assign for the features and the categories, can provide recommendations. It's not like that example that I showed you from my thyroid surgeon, where someone is talking about a mildly suspicious nodule, yet they're not recommending anything based on uniform recommendations. They're just giving a blanket statement of follow-up or refer to your endocrinologist. That really doesn't make any sense. And then finally, we most importantly want to improve patient outcomes. We want to ensure that nodules that need biopsy get biopsy, and nodules that don't are left undetected, so that we improve outcomes. And so here is one of my favorite papers that I've done that looks at number 2, the impact of recommendations. And it's a pretty simple study. It was conducted in private practice, where we took radiologists, about 6 radiologists, and looked at about 600 of their reports at 3 different phases. The first phase is baseline. We retrospectively looked at about 600 of their reports over a period of time. The next phase is we told these radiologists, these 6 radiologists, hey, I want to change how you're dictating thyroid nodules. I want you to use a structured template, and the template has the ACR TIRADS lexicon. This was a paper study that was done when I knew that ACR TIRADS was coming out to be published in about 6 months' time. And so this was a time where these radiologists didn't know anything about ACR TIRADS. So we could give them the template of the findings and the same lexicon, but they didn't know what the recommendations would be. And again, we looked in phase 2 at about 600 of their reports. And then in phase 3, ACR TIRADS was published. We gave them a new structured template now with the recommendations based on the points. And so when we looked at the recommendations in the impression of the report over these 3 periods, we could see that, oh, easy. When we had recommendations, then the number of nodules with no management recommendations went way down. Before that, a third of the nodules had no management recommendations because these radiologists really didn't know what to do. Then, and so that was clear. It had an impact on nodules with no recommendations when we provided ACR TIRADS. That's the impact. But what was really surprising to me is that the recommendation for biopsy didn't change. And that's one of the goals of ACR TIRADS. By increasing the size thresholds for FNA compared to other guidelines at the time, I honestly thought that in these nodules, we would see less nodules recommended for biopsy. But you can see it's slightly increased even, but it's not statistically significant. And that was puzzling until we looked at the nodules and the findings. And this is why. And this shows the impact of a standardized complete report. So in phase 2 and 3, I remind you, this is when we had a template where the radiologist was forced to check every single finding of the 5 findings. And so we see that when there's a checklist, radiologists did that. But when there was no checklist, when it was just free text, just like the report from my thyroid surgeon, Lila, most people recommend report on the composition. That's the basic part. Up to 2/3 report on echogenicity, but then no one commented on shape. Margin was infrequently commented on, and echogenicity also infrequent. So when they're not describing these other findings, is it because they looked at them and didn't see them? Or is it because they didn't look at all? And so if you can see the frequency of these suspicious findings, taller than wide, when it was free text, no one saw a taller than wide nodule. But in phase 2 and 3, when they were forced to look at it, it was actually 4 to 8%. So I would venture to say that there were taller than wide findings, but they didn't see them because they didn't look. Same with suspicious margins. Once you're forced to use a checklist, you're suddenly seeing them more often. And so as a result, the TIRADS points increased, and it was simply because the radiologists looked. And that's why more nodules were recommended for biopsy. And then in terms of impact on recommendations, this is another study where we asked 8 radiologists who didn't know the outcomes of the thyroid nodules, of 100 nodules, to assign the 5 features. And then this again is before ACR TIRADS was published, to provide their own recommendation of whether the nodule required FNA based on what they were currently doing. And then also another thing was to assess their suspicion of thyroid cancer. And the options that were given were highly suspicious, moderately suspicious, mildly suspicious, not suspicious, and benign. And this is what ACR TIRADS categories are. Okay. So this might sound like someone's worst nightmare, that they have to read 100 thyroid nodules, but these radiologists did them. 6 were in private practice and 2 were in academic. These are regular radiologists. And so what did we find? When the readers were asked to give a recommendation for biopsy, they recommended that 80% of these nodules should be biopsied. Only 15 were malignant. When we use their features and applied ACR TIRADS and applied the size criteria, only 57 actually needed biopsy. So that's a significant number of patients saved from a biopsy. And how did we perform on sensitivity and specificity and accuracy? Well, the sensitivity went down. And, that's okay, because we know that For thyroid cancers less than 3 centimeters, the survival is excellent. And a lot of these nodules that weren't recommended for FNA would have been recommended for follow-up. But specificity certainly increased and accuracy really increased. And then one thing that was really interesting to me was this other effect that I saw. This is having done marketing in business school. This effect that we saw when we were asked to assign suspicion for cancer, what the readers most frequently assigned mildly suspicious for the thyroid nodules. When we applied ACR TIRADS and added up the points and put them in the 5 categories, in fact, most of the nodules were highly suspicious or moderately suspicious. And that kind of makes sense because these nodules, 100 nodules, were recommended for biopsy and had biopsy. And so these were more suspicious nodules. And so what effect are we seeing here? This is what we call radiology hedging. This is what one of the radiologists taught me when I was a first-year registrar in Australia. Hedging. When we're not certain, we kind of stick on the fence. And in business school and marketing, we call this the compromise effect. When you're less certain about your decision because you are less of an expert or you're just not sure, you tend to go for the middle ground. And this is what Starbucks did. If you give 2 options to people, then they'll decide, I don't need that bigger coffee anyway. I think the smaller coffee would be fine. But if you give 3 options, then people are going to choose the middle. And so that's why Starbucks has this gigantic coffee. It's so that most people actually choose the very large coffee and they'll make more money, even though you end up not drinking your coffee. So this is called the compromise effect. So I've taught you about the domino effect, and here's the compromise effect. And then, finally, this paper also compared the other guidelines, and you can see ACR TIRADS actually recommended biopsy of the fewest thyroid nodules, which is a 21 to 35% reduction. And again, sensitivity is not really that much different. The specificity was significantly different at 51%, and then accuracy was much higher with ACR TIRADS. And why is this the case? Well, compared to the other guidelines, this is now looking at a registry with the ACR where we looked at almost 28,000 nodules. This is not nodules that are being biopsied, but all nodules that are being reported on diagnostic ultrasound. And you can see that it's the size thresholds with ACR TIRADS that were different for the other guidelines actually moved more nodules from what would be TR3 with ACR ATA up to TR2, and same thing for TR5 to TR4. So the size thresholds and the way it's different actually downgraded a lot of nodules. Okay. All right, so for my final section in the small amount of time we have left, and I'm sorry that we don't have that much time for discussion, some of the challenges we still have are inter-observer variability, and this is particularly with echogenicity and margins. This is one of the examples in a study we had where of the 8 readers that we had, 6 readers would have called this TR5, but 1 reader is calling it TR2 and 1 reader is calling it a TR1. And certainly it looks more like a TR5 to me. And it happens the other way, where nodules are lower on the TR score and people are calling them more suspicious. One resource I have for you is that we put out a CME module that's actually available to anyone for free. And this is the website, but if you Google ACR TIRADS and you go to the ACR website, you'll be able to see this page down the bottom. There's an atlas and also the CME module. And I think that more resources in terms of helping radiologists learn what these signs are always going to be helpful, because if everyone's calling these nodules differently, no matter what RAD system you have, you're still going to be having a lot of variability in the way we're assigning it. One of the other challenges is having so many guidelines. And so we actually put together an international thyroid nodule ultrasound working group aiming to have a universal and international guideline. And so we have representation from Europe and Asia and the United States. But we, in part of putting together this group, we actually surveyed people on guidelines, and it made me a little bit depressed about the mission of this group, because we found that of more than 800 people that responded from 52 countries and specialties, that we needed guidelines because more than 30% are using more than one guideline in their practice. At Hopkins, we use the ATA and we use ACR TIRADS, so that's already more than one. We realized that the choice of guidelines wasn't based on their experience, whether in academic or private practice, whether they biopsied their nodules. It was purely based on their specialty and where they were practicing. So if you were working in the United States and you're an endocrinologist, you're going to be using ATA. If you are working in Korea and you are a radiologist, you're going to be using Korean TIRADS. If you're working in Europe and you are a radiologist, you're going to be using the European TIRADS. People are not choosing these guidelines based on the guideline that performed the best in studies. They're using these guidelines based on their what everyone else is using in their that's nearby. And so this is the network effect. You're, as an endocrinologist, you're not going to use ACR TIRADS because it performs better in a study that you read. You're using it, you're going to use ATA because everyone else is speaking ATA language. And so I realized we can put out an international guideline, but no one's going to use it because they're going to stick to their specialty and where they're practicing. Updates from the United States. We are working on version 2 of ACR TIRADS, and we had a kickoff last year in September. There are 5 high-yield topics that we're focusing on. And as a little teaser, I think there's going to be room to increase size thresholds, again, particularly for TR3 nodules. There's going to be more of a focus on the problematic nodules that get overcalled. And it's nodules like this. It's nodules that have these echogenic foci that are related to the ultrasound, that aren't really truly punctate echogenic foci, but they're comet tails or specular reflectors. There's also going to be a focus on cystic solid nodules, where we truly think that the echogenicity is overcalled in the nodule, in the solid component, based on the surrounding parts being anechoic. So that's a problematic area. And then in the United States, there is actually a new version of the ATA guidelines coming out with new recommendations on thyroid FNA. And from what I've seen with a peer view, that looks really great. So I'm going to conclude here by saying that we have many guidelines throughout the world. We're never going to use the same guidelines, and that's okay. We have the same goals, that we want people to use the same language. We want people to have uniform recommendations, and all of this is to reduce overdiagnosis, reduce waste and costs, and reduce patient harms, because we all care, and you should care very much as well. And these guidelines, you should stick with them. They make us better as radiologists, because we can't all be experts like Franklin Tesla, or who's the chair of the Thyroid ACR TIRADS committee. We can we can practice like an expert with these guidelines, and this helps us improve patient care. And so 2024, I showed you the thyroid cancer epidemic, and I'm happy to say that we're looking a little better based on the updated SEER database. For females, thyroid cancer isn't exponentially increasing anymore in terms of incidence. It's actually going down a little, and that's promising. And for males with thyroid cancer, which was also always less, it's now kind of flattening out, dropping a little. With all of this work, we have made a difference. It's based on just this realization of overdiagnosis and all these societies working on reducing FNA in small nodules and treating low-risk cancers differently. With that, I thank you very much for your attention and joining me on this Sunday morning and evening, and in your case in Asia. Thank you.
Thank you so much, Dr. Huang. That was a very comprehensive lecture, and thank you for sharing all these resources as well. I've now opened the floor for any questions, and we already have one question from Ken. So first of all, spectacular lecture, Jenny. What about patients with a history of head and neck cancers and incidental FDG avid nodule on PET? Do we use TIRADS to describe these nodules?
So the updated ACR TIRADS, one of the projects is, one of the questions, of the 15 questions that we're addressing, is patients in which ACR TIRADS doesn't apply, and an FDG avid nodule would be that case. The chance of that being malignant is more than 30%. And so in those nodules, it wouldn't really matter what you saw on ACR TIRADS. It would be a recommendation to biopsy. That said, you have to think about the whole scenario. If this patient has not, lots of metastases, is a palliative patient, then making a diagnosis of thyroid cancer isn't going to make a difference. And so that's really a clinician judgment. But for all other patients, if there's no other metastatic disease, they're not palliative, then the recommendation would be biopsy that.
Thank you, Jenny. Ken, I hope that answered your question. If there are any other questions, please feel free to raise your hand, or you can type it on the chat box. While people are typing, I did have a question regarding the implementation part of it. So you talked briefly about the inter-observer variability. So did you find any other challenges in implementing it at Hopkins? Did you find resistance from radiologists due to this variability?
Yeah, that's a great question. I think that change is hard. And one of the comments we also received in the forums with the ACR is that this may work in private practice, but it's not going to work in academics. It's too tedious and time consuming, because for these nodules, all of a sudden when they're just describing the size and one feature composition, now you're asking to do 5, and so change is hard. And I think that every practice requires one champion that is going to take the resources that I've shared with you today and bring it back to the practice and gives them the why, why you should care, why you should bother, and really highlight the fact that sure, for each nodule, you're asked to look at more features, but hey, you only have to report 4 nodules, okay? And look at what difference it makes. We can report the same way. We can use these guidelines and essentially reduce the amount of biopsies we do, and therefore we eventually save ourselves some time and do what's best for the patient. Every practice needs one champion to introduce the structured template, to perhaps invite speakers to their meetings, and keep on monitoring and addressing people's concerns. And I think that they're also really great resources. I think there's a great radiographics article on specifically implementing guidelines that I've come across. I don't quite remember the author's name, but you'll get lots of tips from that. At Hopkins, the answer to that, I have only been at Hopkins for 5 years, and they had already implemented ACR TIRADS. So no one quite remembers what it was like before ACR TIRADS, but everyone says it is much better, and they can't imagine life without ACR TIRADS.
Yeah. This might be a biased question, but I'm interested in artificial intelligence. So, have you considered the role that artificial intelligence and automation might play in improving the accuracy and consistency of TIRADS?
Oh, yes, absolutely. One of the other questions was comments from the ACR forum was, this is mind numbing, reporting these thyroid nodules. And I would say that no one in the United States, at least, particularly has any interest in thyroid ultrasound, because you're assigning features, the pathology is just benign or malignant. There's nothing specifically interesting about it. And so you kind of feel like a robot. So enter AI. That would just AI has it will have a big role to play in helping us make interpretation of thyroid nodules less mind-numbing, definitely. And so I know that there are a lot of products out already. I've seen them at meetings. They all look great. And I would love to introduce them at Hopkins, and in your own practices, I encourage you to look into them. Absolutely. And, I think that for all the people out there that have a lot of interpreter availability, they're not experts in interpreting, they're overcalling echogenicity margins or punctate echogenic foci. That's the role of AI. So thank you for that question.
Yeah,
I fully
exciting
support
times.
it. Yeah, I fully support it. Please bring it on. Yeah.
And we do have one final question from the audience. So Tari went, are there any role of using color Doppler ultrasound?
No. So no. According to the ACR TIRADS committee, no. And then I've connected with Steve Colley in the UK with the BTA as well, and he also doesn't think that there's much of a role. And that's why it's not part of the findings.
Okay, I think that covers all our audience questions, and I'll now hand it back to JP.
Oh, thank you so much, Dr. Jenny Hong. It is absolutely, we have no words. I mean, we have learned from the best, TIRADS from the best. So thank you so much for such a wonderful lecture. Again, at AREP, really appreciate that. And thank you, Dr. Sheeran, for moderating this session, for being in Qatar and moderating this session. Great, thank you so much. Really appreciate that.
Yeah,
my pleasure. My pleasure.
Thank you so much. And as I said to JP early on, I fully support the AREP program. You've survived COVID, you're still ongoing, and I just appreciate the enthusiasm all of you have. And I wish you sweet dreams, good night, and happy Sunday. Thank you. Hope you all have a great week.
Thank you so much. Thank you. Really appreciate that. And only it's going to be possible only because of people like you, who are like national stalwarts, but still being very humble and come and talk in our platform. Thank you so much, Dr. Hong.
Thank you.
Thank you.
All right.
And
Bye-bye.
just wanted to, I guess we do have a survey for people in Thailand who wants to get certificate. Please make sure you complete the survey of this session, please. And I also wanted to let everyone know that this would be the last session for this year, but we have a complete session of like whole things starting from January 2025. Before that, before we close out our session on academic radiology education program, which had a wonderful run this year, I want to take a moment to express my deepest gratitude for each one of all the attendees who attended all the entire this year. This program continues to thrive because of your unwavering dedication, your expertise, and the passion of advancing radiology education on a global scale. I'd like to thank all the esteemed speakers for your knowledge, time, and willingness to share insights with the Global Radiology Committee. You guys have made an extraordinary impact on this. And thanks to our moderator for skillfully guiding each session, fostering engaging discussions, and creating an environment where learning thrives. Special thanks to our committee members, especially the IT committee, tirelessly working every other Sunday to make this happen. Thank you for your invaluable efforts behind the screens, planning, organizing, ensuring each session runs smoothly. Your commitment to excellency has been set foundation for another successful year coming up. And it's also my privilege to witness the incredible collaboration and share learning this year. And I'm deeply proud of what we have accomplished together. I look forward to continue this journey, making 2025 another remarkable year for academic radiology education program. Thank you all once again for your dedication and hard work. Wishing you a restful and a joyful holiday season. Thank you. Right, that is the last QR form right there, for evaluate form. Please evaluate this to get certificates. This is especially for people for getting CME credits in Thailand, but also please make sure you fill the evaluation form to get the certificates. Thank you.
Cool. Thank you.
Thank you.
Bye-bye.
Bye. Bye, Dr. Sheedan. Bye, Dr. Deeta. And I see Dr. Kenley here and Tyree. Nice to see you all for the one last time this year. Happy holidays. Happy New Year. See you on the other side in 2025.
Thank you, JP.
Thank you. And also wanted to let know Nat, Dr. Turpaneng is in Thailand currently. She's traveling, so that's why she could not be in this session. And she also sends her best wishes and regards to everyone, and her sincere thank for all the speakers, moderators, and the committee members. Thank you.
Thank you very much, everyone.
Thank you. Bye.